Go ahead, Dr. Neil Patel is our first speaker. Go ahead and introduce yourself.
Thank you. I'm Neil Patel. I'm a resident from Penn State Hershey and a fellow here at Seattle Science Foundation in Swedish. We have ankylosing disorders of the spine journal club today. So my article is on fractures in spinal ankylosing disorders, and I'm going to talk about the three major disorders that we encounter and the injury types and treatment techniques, outcomes. And we have two other papers and two other cases to discuss today, so I'll get going. This paper was published in Journal of Orthopedic Trauma in 2017 by our group. And again, the three major kind of types of spinal ankylosing disorders is ankylosing spondylolysis, AS, and then you have the disseminated idiopathic skeletal hyperostosis, DISH, and end-stage advanced spondylosis multiforme, so EASM, and you'll see me kind of discuss these as we go. So first, AS. This includes, the traditional AS plus any kind of arthritis, so psoriatic arthritis, reactive arthritis, arthritis associated with inflammatory bowel disease, undifferentiated types, etc. The incidence of AS is 0.5 to 14 in 100,000, and of course, prevalence is a little bit higher as these patients live on, and prevalence about 0.1 to 1.4. Men are affected more than women. There's also significant correlation with osteoporosis in these patients. The calcium deposition is changed or altered in a way. And in terms of HLA or any kind of serum markers, 5% of patients with positive HLA-B27 go on to develop AS, but if you look at patients with AS, 95% of them are tested positive. And there's some weak link that has been shown between Klebsiella pneumoniae and the disease process starting. So maybe some infective component playing into this, but not sure yet. So how do you diagnose these? So formally, it was classified by the modified New York criteria in 1984. The key hallmarks of AS are presence of the ossification of the ligaments. And the ossification process involves the discs, it involves the end plates and apophyseal structures, resulting into bamboo-shaped spine that's presented here in the picture. And this could be a confusing finding sometimes if you have multiple skip lesions, which AS is known for. And on top of that, sometimes you could have this sterile spondylodiscitis, which would masquerade as a fracture, but sometimes you just have a segment of bamboo spine and a one or two levels that are still mobile, and then again a segment of fused bamboo spine kind of picture. So that isn't a fracture, that's just a motion segment, but it's hard to distinguish, and that's why when I talk later, you see about 50% patients, more than 50% patients sometimes don't get diagnosed with fractures, or they get, this doesn't get picked up sometimes because of that. So something to think of. And again, with the ankylosing disorders, and as we talked about other arthritis, you could have arthritis in the rib joints, costovertebral joints, and this could cause reduction in your total lung capacity because you can't take a full breath and expand your lung capacity. So these patients actually rely a lot on their diaphragm and overwork their diaphragm to create that space because their chest wall isn't going to open up to give that negative pressure breathe in. So this is also important for surgery and complications thereafter. Something to think of these patients. A second disorder we're going to talk about is DISH. Again, it has a little bit of a male preponderance at more advanced age as well. And then you have clinical trifecta of comorbidities that include pulmonary hypertension, neuropathy, including end organ disease like diabetes and elevated systemic inflammatory proteins, and advanced obesity. So all these things, again, play in terms of morbidity and mortality of these patients pre-op and if you operate on them post-op. The typical disease manifestation of DISH, again, classically includes at least 3 adjacent levels that are coalesced with hypertrophic exophatic bony overgrowth, like seen here in the cervical spine. Most commonly in the thoracic spine, anterolateral ossification is also prominent and more on the right side compared to left because the pulsation of the aorta, something to think of as well. And then the extension of the ossification sometimes involves ligamentum flavum, and could cause spinal stenosis. And this becomes relevant with spinal cord injury and increased rates of spinal cord injury in these patients due to already tenuous space. Again, with this significant lesions up front in the cervical spine, sometimes patients can present with dysphagia as well. Again, the correlation with the serum correlation with this one is HLA-B8 compared to HLA-B27 for the AS. Diagnostic criteria for DISH was defined again by Forestier and then modified by Resnick and Iwayama. The key radiographic difference between DISH and AS is the absence of involvement of SI joint and apophyseal joints in DISH. AS actually starts with SI joint sometimes and can go up or down, and also no syndesmophyte formation in DISH. And then patients with DISH are at risk of acute or subacute neurologic function deterioration, again, because of the high-grade spinal stenosis we talked about. The third type is EASM. So again, this is a variant of the disorders that we're talking about now, and it's a little different because of its etiology. And the etiology in this group is from inflammatory the osteoarthropathies or from advanced degenerative spondylosis, and sometimes collapse of disc space. And because of this, spondylosis mainly occurs in the mobile spine. This entity is usually seen in like cervical or lumbar spine. And again, these patients usually do not attain osseous ankylosis, but they have disproportionately affected by spinal stenosis compared to the others. Something again, keep in mind for these patients. So this paper that I reviewed looked at papers published between 2011 and 2016, and they searched for all the three disorders I talked about and fractures. And we're now trying to find out the complications from fractures, management of fractures, etc. So in the end, they had about 21 articles remaining out of the 559 articles they had reviewed for this. And the result for the average patient age was at the time of injury for these patients about 63. And then most patients were men. Most common comorbidities again included hypertension, coronary artery disease, diabetes, pulmonary disease. So all the things that we already think of that increase morbidity and mortality in post-op from regular surgery. So this just kind of adds to that. Again, ground level falls and low energy trauma was most common type of injury in these patients. When specified in a study, the delay in diagnosis was anywhere between 15 and 41%, and hyperextension fracture patterns were most common. And all of these also had concurrent epidural hematoma that range up to 25%, so a quarter of these patients. In most studies, cervical spine fractures were most common. Second most common was thoracolumbar fractures, C5 to 7 being the most frequently described site of injury. At the time of presentation, neurologic deficits were seen in 21 to 100% of the patients. Operative stabilization and fusion was performed anywhere between 40 to 100% of the time. Mortality range anywhere from 0 to 32% in the first year, so pretty high, and complications were up to 84%, again, because of the nature of this disease, etc. Pneumonia, respiratory failure, and pseudoarthrosis were most frequently described in terms of complications. Neurologic deterioration from initial exam, pre and post-op was noted in 16% of the patient, and patients with neurologic deficits did get some improvement, 6 to 66%. So what we know is these patients get cervical or cervical injury the most. They do get some kind of spinal cord injury. You have to operate on them. Their risk profile is pretty bad. The complications are pretty high, But if you do, then the neurologic deficits do improve. So this is a catch-22 in terms of trying to help them and do right by the patient. So the variables that we need to think of when we see these patients again are, patients with AS are higher risk of fall than control groups, and they looked at low impact ground level falls. Have been associated with spine fractures in these patients up to 65% of the time versus high impact only 31. Whereas patients without these, younger patients without these disorders usually present with some kind of high impact trauma. So very different. Positive sagittal alignment due to the curvature and the way they fuse, of course, adds to risk factors and adds to ODI, daily kind of life and activities of daily living issues. Presence of, again, severe osteoporosis because the calcium kind of deposition in places where it shouldn't and not depositing where it should kind of leads to, and inflammatory disease, again, leads to higher likelihood of fractures. And then unusual injury presentations do happen in these patients where they will present with spontaneous atlanto-occipital subluxation or CV junction issues, etc. So something to think of in these patients when you're seeing them. Diagnosing these fractures, always assume that these patients can have trivial injury mechanisms, but can have pretty bad fracture. A study showed 42% of patients with AS had spine fractures, but did not get diagnosed initially, so it took them a second or a third round of imaging to get diagnosed. 48% of the fractures in the cervical spine could be determined on plain radiographs, leading to recommendation for CT or MRI. So this tells you that 52% of the time you won't even see these fractures on X-ray, and hence you can't diagnose them, and hence these patients have delay in diagnosis. So sometimes you just have to move on to a CT or MRI right off the bat for these patients when you see a radiograph that shows multiple segments that are fused, and you even though the mechanism of fall may not be too bad. And another study found that 48% of fractures in cervical spine could be determined again on plain radiographs, leading to recommendations, as I mentioned. So fracture incidence and distribution mechanism. So in terms of distribution and incidence, Cooper et al. Found that odds ratio of 77.7% for sustaining spine fracture in patients with AS compared to normal population. So they just have at baseline really high risk. And over 30 years, there's 17% chance that they'll have some kind of fracture. Spinal cord injury is about 21% chance. And again, and they could have multiple non-contiguous fractures as well. These fractures could involve transition zones, so they're difficult to visualize. So you have to think of that. And then again, another difference between AS and DISH is the type of injury. So AS patients will get extension injury in 74.4% of the time, versus DISH patients, again, do get extension injury, but 51% of the time, and then there is more for rotation and compression component in those patients. And the other difference is AS patients usually get fractures to the disc space, and DISH patients would get fractures to the vertebral body. Something to think of as well there. And I'm going to stop here. We're going to start with the next presentation, the case report.
Yeah, before we go on, thank you for the very robust review. Again, it's a very dense paper and a very concise review. What are some of the things that you kind of taken away from this in your kind of treatment, both residency and here? These aren't especially common pathologies, but what are some of the things that you feel like, are important in addressing these patients?
Yeah, I think, in training and after reviewing this article, there's always a little bit higher suspicion in terms of injury, and that I started kind of appreciating more when the attendings or when you staff a consult, senior surgeons would say, hey, just get an MRI and let's look at, even with a CT scan and X-ray, we'll get something and we'll see fluid in this space or, fluid going through the vertebral body. So that having a very low index of suspicion, even when the injury type wasn't too bad is important in these patients. And then thinking of, treatment that I don't want to foreshadow, but we're going to talk about treatment, and the way you treat these patients is different as well. And morbidity, mortality, I'm really kind of slowly understanding and appreciating how serious this is in terms of treating, and their initial baseline, and they're not. If you look at a pre-op patient and trying to optimize them pre-op with osteoporosis, with better pulmonary function, better cardiovascular, better diabetes, these patients, part of their diagnostic criteria is to meet them, right? They have to meet diabetes, they have to meet peripheral neuropathy, they have to meet their lower pulmonary function because of that. So I think all of that kind of adds to me appreciating these disorders more, even though the incidence and the prevalence is on the lower side, to have a very high index of suspicion. And I would encourage everybody to not look at just x-rays for these patients, at least CT or an MRI.
Yeah, great point. Thank you. Go ahead and we'll switch over to our next paper. I see we have Dr. Ishak tuning in. Thank you so much for joining us. Any thoughts from you on what's kind of your treatment options? Do you see a lot of fractures in the kind of spondyloarthropathy, both DISH and AS patients?
Yeah, thank you, Dr. Abdul-Jabbar, for having me today. Yes, and we made great experience with that, and we see those patients, especially the elderly, are on the rise. So what Neil previously said, that we try to optimize those patients, I personally feel that we don't have time for that, because we nowadays know that if we treat them surgically, the mortality and morbidity rate is high. But if we just still wait for like better results, I think the mortality rate will get higher. So from my point of view, we actually don't have a lot of time to optimize osteoporosis or diabetes. So from my personal view, I think we should be very aggressive with doing surgery in those patients, because further dislocations may also happen like after weeks, even if you try to treat them conservatively.
Yeah, I think that's a great point. Differentiating, someone who may have an underlying spondyloarthropathy with an elective case versus a fracture that is much more likely to be unstable, and not leaving these patients lying around in bed. I think just like a hip fracture, you really want to try to operate early and mobilize them quickly as well.
Thank you. All right, I've got a recent case presentation for us. This patient is approximately 70-year-old male with progressive swallowing difficulties. He didn't have any myelopathy or weakness, and he had this significant formation of anterior osteophytes representing DISH and ossification of the anterior longitudinal ligament. We do see on comparative flexion extension films, he does have a little bit of a motion segment at C2-3 and C3-4. He was having persistent dysphagia, which was his main complaint. Included this CT scan for better visualization of his pathology. And you can see significant DISH, as we say, anterior beaking osteophytes. One of the considerations in this type of presentation is these persistent motion segments when you have these beaking anterior osteophytes. And really what it comes down to is these are, at least in my perspective, really like treating a non-union at this point. So we elected for this patient to undergo an ACDF at the two motion segments, and then removal of the anterior osteophytes. And you can see on our fluoroscopic images compared on the far left image and the central image, I guess, our left, not radiologic left. You can see that we did what I think is a nice job of removing the anterior osteophytes and then placing our plate with our ACDF. Unfortunately, this man did have a pretty complicated postoperative course. He has had persistent dysphagia. So he had a prolonged hospital course because of his difficulty swallowing, and I've included a swallowing study here. And then, unfortunately, he required the placement of a PEG tube. And after the placement of a PEG tube, he had a traumatic PEG removal, which required an emergent laparotomy. Eventually, he's doing much better now, and is stable. But it goes to show, especially in these high cervical surgeries, people with and when they have preoperative dysphagia, it's something that fortunately we talked with the patient about beforehand, being aware of that as a postoperative complication, and then being prepared, having a treatment algorithm to manage it. And so I would say that the likelihood of somebody having complete dysphagia requiring feedings for the rest of their lives is pretty rare, but it is a non-zero and a real concern, and this patient is a representation of that.
So yeah, thank you for the case report. So this is a case where we were trying to treat dysphagia as kind of the main source of his symptoms. Unfortunately, he had trouble with dysphagia postoperatively. Is this something that you've seen as an indication for spinal surgery in the past, or?
No, I haven't seen it before. There was probably where I was before, we probably wouldn't have been referred this patient, in fairness. So being here, I think, it's pretty impressive imaging. I do think that his quality of life was compromised. So I certainly understand, hindsight's always 20/20, but I certainly understand the decision to go forward with this guy.
Yeah, I think this is an unusual indication, but something that we do see. And, I think the challenge on this patient is that it is so high up. If it's lower down, I think I've seen these patients do pretty well with a fusion surgery and removal of the osteophytes. But it is something that a very illustrative case that you do need to keep in mind and make sure you have that discussion with the patients.
Yeah.
Just wondering if we have our TBI guys on the line. Is this something that you guys see often or would treat surgically? Crickets. Okay, maybe we'll come back. Let's get our next paper up.
Thank you.
So we've got Dr. Brian Anderson with us. Thank you for getting everything ready today.
Yeah, good morning. Let me pull this up. Okay, thank you, Dr. Abdul-Jabbar. I'll be presenting a paper this morning that did come from our center. It's titled Rates of Early Complications and Mortality in Patients Older than 80 years of Age After Surgical Treatment of Acute Traumatic Spinal Fractures, Ankylosing Spondylitis versus Osteoporosis. There's a paper by Dr. Ishak and senior author Dr. Chapman. It's a retrospective case control study, and it was published in Neurosurgical Focus in 2021. Just a brief background. So AS is an inflammatory disorder. A lot of these things Dr. Patel already went through this morning, but its prevalence is quite low, somewhere around 1%. You develop this rigid spine that has a bamboo appearance, which you can see in the top left picture. And you have increased osteoclastic activity, which gives rise to demineralization and weaker bone, predicating fractures, even from ground level fall type situations. It gives you a higher incidence of fracture in these patients compared to normal controls, and the fractures, by the very nature of it being fused, turns into a 3-column injury, which is unstable. So these patients therefore have neurologic injuries associated with their fractures at a high incidence, and conservative management is challenging because it's a long bone fracture at that point with high lever arm mechanics that can lead to displacement and difficulty with healing, especially if they're displaced, but even the non-displaced fractures as well. So treatment of AS is associated with increased complications. We're well aware of that from the prior literature, and also increased mortality. So the purpose of this study was to look at the rates of early complications and 90-day mortality in patients treated with AS fractures, and to compare that to something that's quite well or pretty well understood, compare that to age and sex matched patients with osteoporotic vertebral fractures. So the way that the group went about this was, again, it's a retrospective case control study. They looked at the medical records at a single institution over a 5.5 year period. And they found 11,361 consecutive surgically treated patients during that time frame. 22 of them met the criteria for an ankylosed spondylitis fracture, so that's AO classification B or C, and then 24 patients met the osteoporotic fracture category, and that's an AO A4, unstable burst fracture involving both end plates with discontinuity or retropulsion of the posterior wall. So the inclusion criteria also included a TLIX score of minimum 4 in a patient that underwent open surgery, not minimally invasive, but open surgery. And then in the patients that had osteoporosis, the osteoporotic vertebral fractures, their DEXA scan had to be performed within the last year, and it had to be at least negative 2.5 T-score. And then these patients had to have a 12-month follow-up. Exclusion criteria were tumor and infection leading to fracture. There was a lot of data that was analyzed. Here's a brief list, truncated list. Importantly, the investigators looked at the comorbidities, and they also computed a Charlson Comorbidity Index, which is a little bit cleaner way of figuring out scoring the amount of preoperative comorbidities that the patients have. Statistics were fairly standard. Use stat version 13.1. Less than 0.05 considered statistically significant. So here's some of the data, or here is the data that was obtained for the patients with ankylosing spondylitis, the 22 patients that came out of this set. And they did, the investigators did identify the pre-op ASIA grade and the post-op ASIA grade, and every single patient did improve at least one letter grade over the course of 3 months. There was no change by 12-month follow-up. All the gain was seen in the first 3 months. And then they also listed any minor complications and major complications. And then mortality within 90 days was also identified. So this is a table that looks at the demographic parameters between the AS group and the OS group. And you can see the only thing that's statistically different is the age-adjusted Charlson Comorbidity Index, or the CCI score. You can see it's significantly higher for the AS group. So these patients in general are sicker. And most prevalent comorbidity was cardiac disease. That was the only preoperative comorbidity that was statistically significant. When looking at the surgical characteristics between the groups, there was no difference between surgical duration, EBL, levels fused, or intra-op complications such as durotomy. When we look at the post-op course, however, there are some differences. So our patients that have ankylosing spondylitis, they do have an increased mean ICU stay after the operating room. And they also had an increased 90-day mortality rate. You can see that 8 of the patients, which is astounding, 36% of the patients did not make it past 3 months from a mortality standpoint, whereas the osteoporotic vertebral fracture group had 0. When you look to the table on the right, you can see the 90-day mortality and the reasons for why the patients passed. 2 of the patients had a bowel perforation that led to mortality within just a few days of surgery. 1 of the patients was several months out, and then all these other reasons, ARF, acute respiratory failure, MI, and gastrointestinal bleed happened within 90 days as well. When we look at the 90-day complication profile between the 2 groups, again, you can see the major complications produced 10 patients that had major complications opposed to only 4 in the osteoporotic group. And so that's a statistically significant difference. And you can see that interesting bowel perforation was much higher compared to the osteoporotic group. And then minor complications did not have any statistically significant differences. So major complications are a big concern. So in summation of the results, Three things that are important to note coming out of this paper are that patients with AS have a higher rate of premorbid conditions, which is statistically significant. The CCI score is 7.6 compared to 5.6. Major early complications are, again, statistically significant and much higher. 45% of these patients have early complications, so nearly half, compared to the osteoporotic group, which is only at 16%. And then 90-day mortality is very similar. 45% of these patients did not make it past 90 days due to a multitude of issues, as I talked about before, compared to 0% in the osteoporotic group. The authors went through in their discussion of the paper, and they listed several other papers that commented on similar types of in-hospital mortality and 90-day mortality rates. In-hospital mortality around 10%, 90-day mortality rates 30 to 40%. So it's these numbers aren't unknown. This just bolsters the knowledge that's already seen in literature, but we can appreciate how much different ankylosing spondylitis is compared to osteoporotic vertebral fractures, something that has a much higher incidence, around 25 to 30%. I'm sorry, much higher prevalence, around 25 to 30%, whereas as I discussed earlier, ankylosing spondylitis is only around 1%. So it's less commonly seen, but it's frankly a more dangerous animal. There were some obvious limitations to this study. It was a retrospective study. Small sample sizes, even though it was a large initial population of surgical cases. And then the length of follow-up was brief, 12 months, but most of the data was actually, there's no real significant changes between the 3-month and 12-month follow-up. So my interpretation of the study is there is some difficulties given the study limitations, but it does provide some interesting thoughts that provoke maybe some additional studies that can be conducted in the future. AS fractures are different when you compare them to osteoporotic fractures. They're a different type of fracture with a different kind of pathology, and so it's not necessarily comparable as far as the complexity of the fracture or the morbidity and mortality associated with this. And I think this publication does a good job of highlighting that. I think that minimally invasive techniques are warranted for investigating if they can provide better outcomes versus open. And then conservative management is not always ideal in a long bone fracture for obvious reasons, but with a patient that has a 45% chance of morbidity after the case or 45% chance of mortality within 90 days, I think these are things that you obviously have to counsel your patients on when you take them to the operating room or you offer to take them to the operating room. And then, as I said before, the study leaves a little bit of room for improvement with larger and better quality studies. Thank you.
Well, thank you for the review of the paper. Obviously, we have Dr. Ishak on the line. I'll get a couple thoughts from him. I appreciate you bringing up the limitations of the study. Obviously, it's kind of because this is such a rare, clinical situation that we see, large database study and then small numbers at the same time, which are each kind of problems in and of themselves. But because, big series of these patients are pretty difficult to find, appreciate you bringing up those points. I think it's very valuable. And as you brought up the kind of osteoporosis, how do you kind of look at those differently? Because one of the things that I thought about review of this paper is that it's hard to know. A lot of the ankylosing spondylitis, dish type of patients come in acutely and need more emergent type surgeries. And I don't think that they were really able to differentiate those. It's just the diagnosis of osteoporosis kind of pulled out of a database. So I do think that these are pretty different patient populations that we're looking at, and that's why you see the difference in the rate of complications as well as mortality.
Yeah.
So any other thoughts that you had in terms of, treating these patients? You brought up the idea of, non-surgical management, which was not the focus of this paper. How would you kind of approach that if you were kind of talking to one of these patients acutely admitted to the hospital?
I think it's a very reasonable and appropriate conversation with the patients. If they have a significantly displaced and they have a neurologic compromise injury pattern, then I think that you need to lean heavily towards surgery. But if they have a non-displaced fracture, I think it's reasonable with no neurologic deficit. I think it's reasonable to bring up the conservative management, using some type of brace, maybe a TLSO brace, since a lot of these fractures happen at the low thoracic thoracolumbar junction. I think it's reasonable to talk about that in light of the high morbidity and high mortality rates associated with surgery, and just very close follow-up and understanding that conservative management may fail, and you may need to lean on some kind of surgical intervention. But yeah, it's very different than an osteoporotic fracture where the stress strain curve is much different, and patients can usually tolerate a lot of fracture and retropulsion before they have significant compromise. No hematoma, hematoma is less and such compared to AS. Yeah.
Great, thank you. Thanks. Dr. Ishak, thank you for being online. Again, thank you for bringing this up. What were some of the challenges that you found when analyzing this data for some of the points that we brought up earlier?
Yeah, thank you very much for this presentation and this nice summary. When we went through over 11,000 patients, and we exclusively looked for very, very old patients. And what we've seen is that there were many patients who were treated conservatively with a brace for months, with no dislocated fracture. And the feeling was over 60 and 70% came back after the latest 6 months and underwent surgery, actually. There's a high lever on that fracture. And if you have let's say something between type A or B of the AO, and you tend to say it's more like a B, but no dislocation, but we see involvement of the posterior structures, we had the feeling that those fractures will be unstable, maybe not now, and maybe not the first month of bracing, but 3-6 months later. So we in Germany actually became very aggressive by treating those surgically. And what Dr. Abdul-Jabbar already said, that osteoporosis is really a factor. I mean, it's described 50-60% of literature, but I personally had a feeling that every screw which goes in it's so soft, the bone is so soft, and taking another risk with doing cement augmentation for those patients, and we know the cement embolism rate is extremely high, we tend to be more aggressive. Instead 2, we do 3 above and below. And this is what we already did in those studied primarily. So there was no patient 2 or above and 2 below. So the perspective is conservative treatment is of course an option, but my feeling was that in the end, 60 to 70% of those patients who were treated conservatively in the beginning underwent surgery.
Yeah, I think that's a great point. A lot of these patients may be elderly, they may feel very strongly against surgery. You try bracing them, and just as you described, they may end up being very uncomfortable, unable to mobilize, and end up needing surgery. So again, these are just points to bring up in your discussion with the patients ahead of time, and very, very applicable points. So thank you for clarifying that. All right, moving on here. Second case presentation. Go ahead, Gautam.
Hey, good morning, everyone. I have another case to present, a recent case that we did here. Patient that had kind of complicated history, but also had DISH, so I wanted to kind of walk through and kind of discuss kind of treatment modalities and other things like that. So no disclosures. Patient is an 80-year-old male, previous lumbar laminectomies and fusion back in 2021. He presented to clinic initially with a lot of back pain, worse after a fusion, and then presented to the ED for worsening pain and paresthesias. Initially, kind of all before, he just had some weakness in his knee extensors on the left side. This is his MRI before his first surgery. So he just had a couple of lumbar laminectomies, and then an outside facility, he had this instrument infusion. You can see here in the AP, or the lateral standing films, he already has some bridging osteophytes here and anteriorly, and you can see on the lateral or the coronal CT scan that he also is having some lateral bridging osteophytes. Kind of pretty common for these hyperostotic issues. So we were following him for a while. He ended up having worsening back pain. We consulted infectious disease at that time just to ensure he didn't have any lingering infection, because he had a previous washout for after his second surgery at an outside facility. You can see here that even these patients with DISH and these hyperostotic spondylitis issues have, they're saying, more soft bone, more bridging osteophytes, a lot of degenerative disc, and an easier infection rate. We found an infection a few months after, we found infection and washed it out. Then he fell a few months after that and had a worsening of lumbar radiculopathy. That's when he presented for the ED. This is just a standing film and a CT myelogram of the last clinic visit he had before we took him for surgery. And you can see here, kind of throughout his entire thoracic spine, he has these lateral bridging osteophytes, mainly on the right side. And he had kyphoplasty done previously as well, but you can see that this is kind of throughout his spine, even throughout his ribs, throughout his other joints, really showing that this is more of a overall disease process that has a lot of manifestations in the spine itself. We ended up doing a T10 pelvis on, or T8 to L4 on him, bridging the area that he had actually a lingering infection in the T11-12 disc space, which we irrigated, debrided, and ended up putting a cage for anterior column support. He's doing quite well. He got discharged from the hospital currently on antibiotics, and a lot of his pain is improved, fortunately. So this is a patient that has had multiple surgeries, partly due to his metabolic disorder that he's had and spondylitis that he's had. He's had multiple infections that's kind of accelerated the degeneration that he's had in the spine. And I was always taught, in order for these patients that have these osteophytes bridging to span that construct. So let's say even if it's their pathology is L2-3 stenosis or L2 to S1 stenosis, but they have decreased motion segments higher, it's better to kind of span that in order to really have a rigid foundation so that you can prevent as much adjacent segment disease or mechanical failure as possible, which is what we did with this patient.
Great, thank you for going through that. If you want to pull back up the imaging, just so we have some visual to look at, those first images. So, I think it's challenging when you have maybe someone with, single level disease, trying to have a conversation as to, we need to do a bigger surgery as opposed to a less invasive surgery. What do you think some of the things you might have, obviously in retrospect, it's very easy to change your course, but if you were to see this patient initially, what are some of the conversations you might have had?
Yeah, I think initially going to his, first preoperative MRI, he mainly just had, stenosis, not a lot of motion segment. His discs are pretty degenerated, but I would have offered just simple decompression at that time. It looks like even at the, this is a L4-5, or L3-4 area here is not too bad, but here's kind of the worst, and this disc is almost autofusing. So I would just probably do a simple decompression. You can always do more, hard to do less. Hard to go back and revise things, but he really just kind of had claudicatory like symptoms. I probably would have just done a simple decompression, and then with these patients I've seen with, AS dish, they always, they like to fuse. So either he'll auto fuse on his own, or if he does fall or have a fracture, then you can obviously treat that. But once you start really kind of rigidly fixating parts of the spine in these patients, they tend to kind of fall apart a little more easily, just how degenerative the nature of their disease is, I've seen.
Yeah, I just, and I again, obviously this came from an outside facility,
Right.
so we don't really have that insight, but, just thinking, if you look back at the previous MRI, we're looking, again, we don't have all the images, but it looks like the 4 or 5 stenosis is the worst.
Correct.
The 3-4 level was instrumented. So, do you feel like that may have played a role in why he was unhappy with the previous results? Or?
Possibly. It seems like, again, they probably fixed one part, didn't decompress what he had, worsening pain, and then just that motion kind of accelerated things, especially with his infection postoperatively. All the inflammation really kind of affected everything, I think.
And I think you bring up a good point with, we aren't really focused on decompression alone here in, these hyperostotic spondyloarthropathies. I do think that these tend to be very stable spines. And so, although there may be very degenerative changes, doing a decompression alone, I've seen patients do very well with that. So, obviously we're talking about infection and instability later on. But that's something that is very applicable to these type of patients as kind of a first line treatment, because when you have these long segments that are fused, you are looking at doing more and more levels, more and more surgery for these patients that may do well with just a decompression alone. Bassam, any thoughts on that case?
Yeah, absolutely. I guess the level which was like responsible for the symptoms was not treated. So I can't understand why they treated L3-4. Maybe it was easy to get in a cage compared to the level below. Yeah, simple decompression, always first choice treatment in those patients. You never know what's going to happen. And we often see those patients again because they need adjacent fusion, or they have a high failure rate for implants. So I think decompression first choice. And other thing, like in those patients, what I've done like the past years is like to take like whole X-ray films of the whole spine. Sometimes I have the feeling if you do just a plain lumbar X-ray, it looks fine. If you go to the thoracolumbar region, you have the feeling, oh my God, bad alignment. This is like my thought on it.
Yeah, I think that's a great point. When you're looking at these types of ankylosing spondylitis or a dish type picture, having a bigger view of the spine, looking at their alignment, you do want to just take a step back and see the whole picture. So yeah, thank you for bringing that up. All right, our next case here, or a study looking at Cliff Pierre. Go ahead, come.
Again, good morning, everyone. My name is Cliff Pierre, one of the fellows here at Swedish. This morning, I'd like to discuss an article that actually came out of Germany, one of the major trauma hospitals within the BG system in Halle, Germany, at the Bergmannstrost Super Regional Trauma Center, and discussing open versus minimally invasive treatments for ankylosing spinal diseases. And so, again, Dr. Patel gave us a very thorough review of the type of fracture patterns that occur with some of these patients with ankylosing spondylitis, many of them commonly being AO classified type B or C, specifically B3, causing hyperextension or distraction injuries, and many of them occur likely due to low energy trauma from either ground-related falls while standing or walking. And these patients have a higher risk than patients that don't endure some of these injuries. One of the things, the goals of the paper outlined was fracture reduction in terms of surgical fixation, irrespective of open surgery versus minimally invasive surgery. In these article here, what they alluded to, again, from another journal article, this hyperextension injury that occurred at thoracic level T12, they did fixation using bending rods as well as a mobilization to help reduce the fracture at the site of injury. And so that's one of the things that was discussed in the background for this article. But the hope is that irrespective of surgical procedure, fixating them and reducing them helps promote osseous healing and prevents any further neurological deterioration. And again, the article discussed technical advantages between open and minimally invasive procedures. Minimally invasive, again, having less soft tissue damage, less issues perioperatively with respect to blood loss, as well as postoperative complication rates, versus open surgery, where you can actually visualize some of the anatomical landmarks with respect to pedicle screw placements. And the hypothesis of the group was that open surgery had advantages over MIS in terms of reduction quality. And so one thing they wanted to study was the correction angles between preoperative and postoperative films, and then also looking at all the factors perioperatively to see if MIS would be superior. And so they did a retrospective review over 10 years from 2009 to 2019. All these patients underwent posterior spinal fixation, multi-levels in the thoracic and lumbar regions. They all were adult. Images were reviewed by the lead author, Dr. Kohler, just identifying AO spine classification type injuries, fracture morphology, studying the Hounsfield units to understand the bone mineral density, because many of these patients, as discussed earlier, can also have osteoporosis, and then also identifying pedicle screw fixation and utilizing the Gertzman and Robbins classification with respect to placement. And so they also studied the perioperative factors, such as blood loss, surgical complications, as well as their hospital stay, and statistical analyses were performed. A total 75 patients met their inclusion criteria. 48 underwent minimally invasive spine surgery, while 27 underwent open surgery. One other thing in the results, they noted that there was no difference with respect to some of the descriptive data. And so this was identified in the second table within their chart. One thing that they did uniquely was adjust many of these not only perioperative factors, they adjusted to the AO spine classification to understand, again, p-values less significant, less than 0.05. And what they noticed, there was no difference with respect to the energy of trauma, whether high or low, between either treatment groups. However, again, the distribution of the injury, there was a difference, specifically between B3 and type C injuries in these patients that underwent either open or minimally invasive treatment, as well as the surgical time with respect to skin-to-skin incision was significantly lower in the MIS group. Perioperative blood loss was higher in the open surgery group. As noted, they did a calculation not only studying the external blood loss, but also the total intravascular volume by monitoring, again, what is absorbed in the surgical wipes, as well as hematoma within the open surgery field, as well as, again, during the hospital stay, they noticed that there was no difference in the ICU stay between both groups. However, the length of stay was longer in the open surgery group. With respect to the distribution of injury within the thoracolumbar regions, there was no significant difference between MIS or open surgery treatment. CT imaging did not identify any significant differences between the groups with respect to the primary fracture malpositions of any of the screws. And then the correction angle, which is one of the goals and hypotheses of the paper, they noticed that there was no difference between MIS and open surgery treatment. No difference with respect to Hounsfield units. However, they did note that close to 68% of these patients had Hounsfield units less than 110, likely leading to osteoporosis, which is what we see is common as well in the literature, as well as in surgical sites. So complications, 2 patients had deep surgical site infections in the open surgical group. 1 patient had to be taken back for bleeding complications in the open surgery group for revision. All patients that had any preoperative neurodeficits pre-op, whether it was open or MIS, they did not have any further neurological deterioration after surgery. There were no mortalities in either groups. And again, there was no significant difference with respect to misplaced screws. However, they did note, again, a higher amount of malpositioned screws in the open surgical group. So limitations of the study, again, being retrospective in nature, one thing that they did not have was any follow-up studies or findings after their hospital course. They did not discuss any assessment scores with respect to functional outcome like ODI mentioned by Dr. Patel. They did not disclose where these patients were discharged postoperatively in terms of their hospital course, whether they went to SNF or rehab. And then again, they calculated blood loss was identified but not measured. Take-home message, neither technique can improve the trauma-related malalignment. So there was no difference with respect to the correction angle. So the reductive effect of the fracture was low within both groups. So this again met opposition from their hypothesis. However, with the small sample size, again, this could not be confirmed within this group. And then again, implant positioning similarly with respect was noted to be safe whether you did open or MIS. And then MIS had superior perioperative parameters with respect to the surgical time and the shorter hospital stay and blood loss. Discussions. This study was done in Europe, and so that we have Dr. Ishak with us from Germany as well, can maybe further weigh in terms of his patient population versus when he was here in Seattle for a fellowship, in terms of comparing these population groups. MIS, again, was, and since 2011, became a preferred alternative treatment style for management for many of these type of injuries. And so one of the things is selection bias with respect to surgeon preference and including the severity of the injuries. If they're more severe, many of them went open surgery. They used a rigid rod for this group. Some papers talk about using less rigid rods so that they are more mobile, using the mobilization techniques or bracing techniques after surgery. And then again, longer term follow-up or data could be included. More modern technologies in terms of MIS versus open with respect to navigation assistance. And then as Dr. Ishak disclosed, augmentation of some of the fixations was not disclosed in the article, and many of these patients also identified to have osteoporosis. I open the floor for further discussion related to not only the journal, but also some of the things we discussed earlier today. Dr. Abdul-Jabbar.
Great, thank you for the concise review. I think it's a very valuable paper. I treated these both open and MIS, and I think they're both effective. I really appreciate you bringing up the point of selection bias, because I think there are a lot of factors that may push you towards one or the other, especially if there is a long lever arm. I do think it can be challenging to pass a rod over multiple segments, and a bigger construct is obviously going to be higher blood loss and more invasive procedure. Dr. Ishak, how do you like to approach these? Open MIS, cement, no cement? What are some of your thoughts?
So first of all, I try not to use cement because we've seen like what we published on that, like 60 to 70 extravasation, especially the higher you go, like for thoracic issues. There's like what we've studied anatomically at Seattle Science Foundation is that we've seen a connection between the cava and the vertebral body, a direct connection. So we've seen many patients with cement directly in the cava vein. And what we've seen also that we have many silent pulmonary embolisms in those patients. I mean, they are asymptomatic, but still, what you're going to do with cement inside the pulmonary system, So we therefore try not to use cement. And in terms of MIS or open, I think both are absolutely reliable techniques. I mean, if it's in the middle of the night, I prefer open because it's still fast. And I think if just the thoracolumbar region, you're very quick at the point. And what we do actually is to use like emerging technology like navigation. So this is what we use because we know the anatomy is very bad due to this inflammatory process. And when it comes to MIS, I think doing MIS and navigation is also a valuable option. So I think both are good options. In terms of reduction, we leave the gap open. I mean, we've seen, thanks to Dr. Pierre, that it doesn't make like any difference. And from my personal view, I think it can cause more complication. You try to reduce something, and you know the screws are in weak bone, so you don't want to get any screw failure, and you want to reduce the surgical time and not like spend another hour with the patient on the OR table to try to reduce the fractures. And we've seen, like also in the past with good results, there's no problem leaving the gap open.
Wonderful points. Thank you. Scott, thank you for tuning in and being with us. Any thoughts in terms of how you guys treat these AS and DISH patients? I think we've got you on mute.
Yeah, that was my cricket button for being Dr. Cricket. So I'd like to actually go back to the dysphagia question because in 30 plus 3.5 decades of practice, I've been convinced by an ENT doc once to take down dish osteophytes for dysphagia. So I think it's extremely, extremely rare. Since I'm not the trauma maven, I have none of my trauma colleagues on with me. I'm not going to comment on the last trauma paper.
So you did one osteophyte takedown for dysphagia. How did that one go?
Short-term follow-up because since I didn't put any hardware in, I didn't follow them very long. They had immediate relief. I did a lot of bone waxing after taking it down. Whether it eventually grew back or not, I don't know. It was an ENT problem and have not been asked to do. I've had some patients that have asked about them because they look at their x-rays, but it's like the other comment in the chat room, it's just extremely rare to do anything but treat those non-operatively.
Great, Dr.
But
Guy.
I mean, I also have done one, and it's extremely rare. But you've done one, I've done one in 30 plus years.
So we've got a case series of 3. 2 did well, 1 not so well. So do with that what you will. But,
That's what if we'd had this conversation 10 years ago on SI fusion, that would be similar experience. But in the last 10 years, it seems like that's certainly changed.
Great. Well, I don't want to keep you guys too much longer. We're already over time. I appreciate the fellows preparing the cases and Dr. Yushak for tuning in from Germany. And thank you guys for participating as well. And thank you for being with us here for Journal Club.
Thank you.
Take care, and everybody have a great weekend.
Thank you. You too.
Hey, Corey, you going to flash the number for the credits?
45.
1045.
Okay, thank you.
Yeah.
Tell Lexus we really like those fellow gray jackets with the personalization Seattle Science Foundation. Those were nice.
Oh, great. I'll tell her.
Have a good weekend.
You too. Bye-bye.
Bye-bye.